want to introduce Dr. Mary Naylor to all of you formally. She is the director of the New Cortland Center for Transitions and Health at the University of Pennsylvania School of Nursing. And since 1998, Dr. Naylor has led an interdisciplinary program of research designed to improve the quality of care. She's also the National Program Director for the Robert Wood Johnson Foundation's Interdisciplinary Nursing Quality Research Initiative, and has many, many honors and responsibilities. But I wanted to spend a moment just saying that I really feel like this is a homecoming for Mary, even though we haven't officially met until this morning. My sense is that all the themes that are really instrumental in your life around quality, care, finding innovations, developing new ways of doing research, translating research into policy, those are really part of your roots, and this is part of your home here.
Yeah,
between the Institute for Health and Aging and the new Health Workforce Center and the Institute for Health Policy, we have a community here of like-minded folks, and are very, very interested to hear about the lessons that you're learning. So welcome, Mary.
Oh, well, thank you all, and Claire, for that terrific, warm and generous introduction. And in many ways, I do feel as if this is a homecoming because I've, over the course of my career, have had the great fortune to interact with many of you, treasured colleagues, and now to meet some new ones. I'm really excited and thrilled to be spending the day here with you and as part of this presidential chair opportunity. I thought I would start by just telling you a little bit about how I'm spending the year here at UCSF, and talk a little bit about, of course, the presentation and your comments about and questions about that, but also as you think about how I might be able to help you in any way over the course of the next couple of months, and as Claire said, into the future. I'm delighted to do so. So David Vlahoff, I think this was well over a year ago, Dean of the School of Nursing, but we did not know each other well, and he said, I have an opportunity I would love you to consider, and he actually framed it exactly as Claire did, which is to think about the kinds of ways in which the work of our team, not just myself, but our team at Penn and now Far Flung, and the areas of inquiry and efforts to move evidence into practice and to really help use that to shape policy, both in communities, in states, and across the country, how this aligned with so much of what was going on at UCSF, and how I might be a catalyst to come, as you often do, you have to go 3,000 miles away, to think about ways in which you, all of you, us together, could advance this work. And so this couple of weeks, for example, I'm spending in the VA tomorrow to talk with them about how it is that their programs around care management, case management, around the theme of vulnerability can advance their thinking and the way that they're delivering services. I'll be spending time at UCSF Medical Center a couple of days talking about, in fact, one of the major themes is around workforce and what it means to think about building a workforce as we're flying a plane and changing our healthcare system. So real energy and attention on the current workforce as well as implications for the emerging workforce. Thinking about integration of multiple models of care to more intimately align with the needs of patients and family caregivers on their journey. Thinking about value and the context in which we can all build our energies and put them together to get to higher value for the people who are counting so much on us, and for a society whose resources are becoming increasingly finite as we grow, for example, every day 10,000 new people in the Medicare program. So there's tremendous opportunity. I'm also going to be spending time with Collaborative, UC Collaborative, the 5 UC schools, and all of their efforts and programs to think about advances in care and outcomes of arguably our most vulnerable populations. So it's really an extraordinary opportunity for me, and I'm really delighted to be starting this visit with you. Look forward to the conversation that follows. So Joanne It was really, I think we met at Ella's last time, and we speak almost weekly on the phone for other reasons. Thought it would be a great opportunity if I spent some time today with you talking about an area that you have mutual interest in, and that's the notion of how do we move evidence once it's established into real-world, living, organic, breathing systems, and what is it that we can learn from each other in this process. So that's what we'll talk about, but I hope in Q&A you'll be open to ask anything that you want of me related to our shared interest. So just to give you a sense of background, many of you know that for many, many years, I've had the great fortune to work with a team, a multidisciplinary team of scholars from nursing, medicine, healthcare economists, people from social sciences, all who have given so generously of their intellect and time to think about care delivery in the future for a population of increasing vulnerability. And so our work has, we had a name, and we have a name to it, the Transitional Care Model, and these are the core elements of the model as it has evolved. It is not at all where we started, but the science has helped us to understand what are these critical elements, and I'll be coming back to them. But they start with identifying the population that we want to serve and who will benefit most from this service. Real focus on the issue of patient and family caregiver engagement. We learned very early on that we could have a positive impact on care and outcomes, but that it was short-lived because we did not pay as much attention as we needed to real engagement of patients and families. So long before it became the language du jour, we knew how central it was to really get patients and family caregivers to be central parts of the team. We spent a lot of time on learning about managing symptoms. Of course, all those clinical guidelines out there that help us to manage one disease or another have not really prepared us as clinicians to be able to manage the complexity of challenges that confront people who wake up every day with heart failure and diabetes and depression, all in one human being. And the other principles, components of the model, are things that we all learned in all of our respective disciplines. It's about teams. It's about really effective collaboration. People care most. If I had to say that there was one theme that's emerged from our evidence over the years about continuity, they want to know who it is to whom they can turn when they have questions and issues, to help them, to advocate for them, and to make sure that they can help navigate an increasingly, and I do say that, fragmented system. But fundamentally, this is all about trust and building the kind of relationships with people that allow all the rest of this to happen. So other features of the model is to give you a sense that this is both a care delivery orientation and care coordination, and it really in that way is distinct from other approaches. So for example, in our work early on, we relied on advanced practice nurses, and still to this day, who are both delivering services to people while in the hospital and coordinating their care. They are then following them into skilled nursing facilities, into the homes, delivering services, substituting for traditional visiting nurse services, for example. So this is really a central part of thinking about the redesign, that this was not additive, it's not about connecting dots, it's really about thinking about fundamentally redesign of systems to align with people's needs and also to make sure that they are efficient and effective. People don't want 5 different people in their home delivering care. They want someone to do that. 7 days per week availability. The service is across the settings. Over time, we built an evidence-based protocol that guided the work of these nurses and the teams with which they collaborated, so that people knew when they went into someone's home a day after discharge what were the common issues and problems that they were going to have to assess. So they were guided by that, but it relied tremendously, and still does, on the clinical judgment of these clinicians, nurses interacting with physicians, social workers, and other team members. And over time, time, we built decision support systems. Although one of my daughters, when she saw one of the first ones, said, well, that's a 1.0. And I said, well, what is that? I said, that sounds excellent. She said, no, it's not really excellent. But anyway, but we've become increasingly sophisticated in the information transfer systems and so on that we've developed to support their work. So fundamentally, this whole model focuses on people, older adults at risk, older adults who are both cognitively intact and cognitively impaired as they experience especially vulnerable times in their lives. Goals of the model are to move people who are at high risk to lower risk, and enabling them to get back to a better position to be able to manage their care, but also to avoid the use of more costly services in that process. It has been tested via multiple NIH-funded randomized clinical trials and NIH-funded comparative effectiveness studies where we compare the transitional care model to other evidence-based approaches and consistently been demonstrated to do better than standard care and better than other evidence-based approaches. And we thought that that's all you needed to do, but of course you all know that that's not the case. We focused on multiple domains. This was set up as a model to improve people's experiences with care and their health outcomes. And of course, you know, while doing that, when you do that, you're able to reduce avoidable use of costly services and reduce total cost of care. And it's been recognized by the Coalition for Evidence-Based Policy, a MacArthur-funded group, who took a look at independently at our evidence as a top-tiered evidence-based approach that, if scaled, could have a major positive impact on the care of Medicare beneficiaries in this country. I have no idea what I'm doing. I'm avoiding that button. So I guess it was, I don't know, maybe 10 or more years ago, again, we have this work, clinical trials published in what we think are all the right places, a lot of publicity. We had stories in the New York Times and Washington Post, and we think we've done it. We've accomplished our job. We have really shown an approach to care that meets, we now call the triple or quadruple aim. And quickly learned that there were there were no systems that were taking this up and using it as a basis for system change. We were constantly scanning the market to see who out there is using this evidence as part of their redesign effort. And so we decided that it was going to be very important for us to, and we were also confronting constantly the question, well, that works because it's a Penn initiative, or maybe it works because it only works in clinical trials and comparative effectiveness studies, but it's not going to work in the real world. So we took on the challenge of saying, well, does it work in the real world? This, by the way, I hope you'll ask me questions about how we ultimately landed on the model, because it was not without many paths that failed along the way in order for us to really build and mount this translational effort. But ultimately, with the support of 5 foundations, we really proceeded with the deliberate effort of trying to move evidence into practice and determine whether or not we could replicate the clinical and economic outcomes we had seen in the trials. And here you can see the foundation. And we learned over time that success requires more than we ever knew when we started. It requires that we have rigorously tested translational tools, and I'll tell you a little bit more about that. And that was part of the ingredients for success, but the other part was having partnerships with champions in the health systems, in the communities, in the payer community, who were going to really work with us in making this happen. So I'll explain a little bit about how much we learned. So over the first couple of years of our efforts, we're not running clinical trials anymore. We had to build tools of translation so that if we wanted to, we could have this work as effectively in San Francisco as it did in Philadelphia and the suburban communities where much of the testing had been done. So we had to build patient screens, recruitment scripts. We had to literally develop, and we have an online course to prepare teams to be able to implement the transitional care services, because we are still not preparing members of our workforce adequately to be able to implement models of care that cut across settings, that require you to navigate people with high level of complex clinical needs, to also having the generalist skills you need to be able to help them mobilize resources within the community. We had to build performance improvement processes, documentation systems, quality monitoring protocols. The only thing we actually knew at the beginning were we had the evaluation protocols pretty well set. But all the rest of this, we actually had a base in this, obviously, to run the clinical trials, but now we had to make all of this operate in a way that we could wrap it up in a box, not really, and send it to you so that you could work with it. So early on, one of our first champions in all of this, and this was an interesting story. Penn was very interested in this work. It was at a time in Penn's history where they were moving their Office of Technology Transfer to not just promoting drugs and devices and so on, but really wanted to see whether or not they could help to move models of care much more broadly. And they had commercial aspirations with all of this. So we built businesses that failed. I mean, it was pretty extraordinary story. But finally, Mark Pauly, who's many of you know, world-class healthcare economist, we're at a dinner and he said, Jack Rowe is sitting at that dinner and you should sit next to him and convince him, because Mark considers this a slam dunk. He can't figure out why it's not being used. Sit next to him, make the case. And so by dessert, he was so tired of me that, he said, absolutely, we'll begin to work with you. And he sent to me a treasurer, Randy Krakauer, who was at that time head of Medicare for Aetna. And Randy and his team began working with us. And he became, when I showed you that left side of the box, the champion for us, as did many of his leaders within Aetna to make this happen. So we rolled this out in the Mid-Atlantic area, and Aetna then compared our performance to what was happening in northern New Jersey, New York, and New England. So they were looking at all the claims data, et cetera. And we had to demonstrate in this that we were going to get to higher quality, better experience with care. Aetna suggested we measure for the first time physician satisfaction, because if they were going to move this into their Medicare markets, they wanted to be able to have the case that this added value to physicians, and physicians would not begin to say, oh no, not one more case manager, care manager in my service, but rather this adds value. So that was very important. We were able to demonstrate, despite multiple challenges, legal, policy, we actually did some work here in California where we had to work with the state because home care nurses at the time were the only ones who were able to touch patients. Ours is a care delivery model, and the nurses are following patients from the hospital, if referred into skilled nursing, into the home. So we had to work with states to get regulations changed to make some of this happen. So none of this is easy, but ultimately we were very excited at the end that we had some positive outcomes, not 12 months reductions in all-cause readmissions, which we had demonstrated in the clinical trial, but 3 months. And fortunately, Aetna demonstrated cost savings for this program. What was also important here is that here we were not just testing the transitional care model with Medicare beneficiaries in Aetna's program in the Mid-Atlantic region, but we were looking at the added value to a program they already had in place. They had a case management program in place. We're now asking if we target high-risk people and add this, integrate this to their case management program, would we get to higher value? So that was really important to them, and fortunately we did. I wanted to share with you more recent results because we are continuing to work with this program and strengthening, it's strengthening all dimensions of it, but really looking for the program to have more of a longitudinal population effect. And these are recent findings in our own health system. We have finally developed a service line called the Transitional Care Model service line, which uses all elements of our program. We help to recruit and train. We do the quality monitoring, the evaluation, And we are doing it in a learning health system model, so that the health system, the clinicians, the payers, and our team are all partners in trying to figure out how continually to get it better. So IBC, Independence Blue Cross of Philadelphia, is paying for this service line to happen, and they've helped to establish what the target goals are, both quality and in terms of performance, and this gives you a sense of recent findings in terms of rehospitalizations. They're not interested at all in 30 days or 60 days or 90 days. They're interested in 9 months, a year, really moving toward a model of where systems such as ACOs and others are taking on increasing risk. So about a year ago, we had received a call from Laura Leviton from the Robert Wood Johnson Foundation. Laura is working in their new orientation to think about how we move evidence into practice, but very much focused on the notion of adaptation. That with the realization, as we've come to realize, that systems don't take a model and embrace it and say, we're going to do it exactly the way the Naylor team or the Coleman team or any of the other teams have done it, but rather they think about how we take elements of the model, core elements of the model, and move it and adapt it to their values, and so on. So Laura has resources to target 3 different teams. I think we competed with about 15 or 20 other teams that had shown rigorous evidence for an intervention or innovation. And we were one of 3 selected. And what we agreed to do was to try to kind of really get a sense of what was going on in the US in terms of adaptations of the transitional care model. And we decided to focus on adaptations looking at this from the perspective of the clinicians who are delivering the service or the clinical leaders who are designing the service. Rather than going to the CFOs and CMOs and CNOs, we were going to really engage people who are actually designing or implementing the service to learn about adaptations. So we said we will do that. We'll try to classify the common adaptations. We'll try to understand why they occurred. Were they deliberate? We know what to do well, and now we're deliberately adjusting this because of, so what were the opportunities that they were seeking? What barriers were they trying to address? We use advanced practice nurses. We hear in different parts of the country that there are not many advanced practice nurses that you can draw on. So what were the barriers that they were trying to address? And then finally, we wanted in this phase of our work to understand how these practitioners define value. And whether or not they saw their perspectives on value were different from those of the organization or system in which they worked. So this has really been, I think, a pretty exciting journey for us. We started by trying to get a sense of, first, who out there is using the transitional care model. What hospitals, home care agencies, hospices, community-based organizations, integrated health systems, standalones. Well, who out there is using it? We knew some because people are participating in our seminars, and we're working with a number of local health systems and communities throughout the country in their deliberate efforts to apply and use the transitional care model. So we knew that, but there were many we didn't know. So we used a kind of snowballing technique, which was we reached out to everyone that we knew and anyone that we thought of that might have and be using evidence-based transitional care services. So we reached out to all of the Center for Medicare Medicaid Innovation demonstrations in which there was a focus on care coordination. We reached out to all of our friends in nursing and medicine, the National Transitions and Care Coalition, but in essence said, can you help us get this survey into the hands of people that might meet this criteria, might be delivering services. And by the way, if we reach out to you in an organization and you're delivering it and you're partnering with a community-based organization, could you connect us with them? And so that was phase 1. We're now in phase 2, where we're working with sites to learn now the deep dive, to actually learn much more than you'll ever learn in a survey about what actually is going on in terms of adaptation, what is the rationale, and what are they learning. We came at this with the view that adaptation could be terrific. I mean, adaptation could increase reach. It could increase access to services. You know, the adaptations, if they're owned by the system and community, can really add value. And we wanted to learn that because that's a way that we can learn to continually get better at our work. We also wanted to understand at what point does adaptation so not compare with what the evidence suggests is going on that it could actually be harmful. It could be detrimental. And so when you hear people saying, for example, well, we're using the Naylor model, you go, are you? What are you doing? I mean, you have to really think about that. So anyway, so that's what we're doing, and we're using a framework to categorize these adaptations. So let me just give you a little sense of the survey in phase 1. So we started out ending up being able to get a couple thousand providing consent. About a half of them started to give us some information about themselves. Even smaller number actually began the survey, and smaller number, 600 or so, completed it. So we end up with 582 who meet eligibility criteria. And these are independent, so you're not talking about 5 in one setting. This is a clinician or practitioner in an individual setting that is helping us to know what they're doing. So this gives you a sense, and here I'll have to fill in what does that 8% mean, of how these respondents, 582, talked about their use of transitional care. 8% of them said we are using the transitional care model only in our system. That's all we're using. 51% said in our system we're using the transitional care model plus Project Boost plus Project Red. So they're using multiple existing evidence-based approaches to achieve this. 19% are not they're using an evidence-based approach, but it has nothing to do with transitional care. They have other models that they're doing. And 22% say they're not using evidence at all, that what is going on in their system is a homegrown orientation to changing practice. Well, this is important to get a sense of what is happening in the market. I wanted to get back to you because before we actually went into this, we had already done this, but we had to be now with such clarity operationalize these core components because we're looking at adaptations relative to each of these core components, and some of them were quite easy. So screening, a system had to be targeting at-risk adults. They had to use some kind of risk profile, and these had to be targeting older adults transitioning from hospital to home. So we could very easily establish whether or not someone was adhering or not to that. Program staffing, the system to meet our component is using advanced practice nurses who are responsible for the care throughout the entire episode of illness. Not door-to-door hospitalization, but from the beginning when it becomes high risk through whatever part of the journey until they're at a lower risk. We never say low risk. But some of them were much harder. How is it that you established maintaining relationships and so on? So we really, before we even implemented this, had to come to real agreement, and that took, by the way, we have a fabulous National Advisory Committee for this work, as we do for every project we have. That took a lot of work to just come to consensus on what how we were going to assess that this site was implementing each of these components, and these are the other components. So now let's focus on the 350 of those 582 that said that they are using the transitional care model, either alone or in combination, largely in combination with others. And what were the most common adaptations that they reported? Staffing, the first one was staffing, with many of them, 39, almost 40%, relying on registered nurses, but others relying on registered nurses and social workers, or a group they called case managers, whom they didn't define as having one discipline or another. And the second major core component for which there was adaptations was the issue of continuity. Now remember, early on I said continuity to people is everything. I mean, people want to know who's in charge. A trusting person throughout the entire journey is central to success. And here we saw in our approach, the advanced practice nurse, the same one who begins to work with you on the day of hospital admission and with the team and you throughout, is the one who's in your home the day after and following you through that episode for an average of 2 months post-discharge. So that continuity. Now, I always have someone, well, don't people get vacations and so on? Yes, but we've worked it out. But largely, this is the person who's in charge, on top of, that you can call on for any questions, concerns, et cetera. But the adaptations were different staff were delivering. So some people were delivering who were based in the hospital, part of the model, and others doing it once they went home. And a very substantial number, 32%, were using only telephone follow-up. And our model is in-person visits plus telephone plus email plus every form of contact imaginable. All right, so now we're in phase 2, and we've selected to now do these in-depth interviews to really, really get at it, because we learned, all of you know this, but there are real substantial challenges in getting reliable data from surveys alone, which we've learned in this process. So we are doing these site visits. We're very much informed by phase 1 findings. We really want to understand why you made these adaptations, what adaptations do you make, why did you make them, what were the barriers and facilitators, what do you think will be the outcomes of this work, et cetera. And we also wanted to get a sense of future plans. So we had purposeful selection of the 30 interviewees, diversity of organizational type, geography, and number of core components. Realized that we had people who are responding who are using a couple of core components versus those that are using almost all or all of them. So we wanted to have different perspectives. This gives you a sense of the organizational type. Largely hospitals, but we were really anxious because transitional care is not a hospital service. It's a service that aligns with people's needs at different risk. Our work right now is increasingly moving into the community to figure out how we can use transitional care in collaboration with primary care to prevent people from ever coming into the hospital, et cetera. So these are the different types of organizations, and you can see we were trying to make sure that we got all of our criteria met. The analysis to date is we're doing a content analysis to identify recurrent themes, and then we were trying to look at what themes are we learning about adaptations within organizations as well as across organizations. So adaptations are not just happening across sites, but they're happening within hospitals related to each of these models. So here I'm going to give you some very preliminary findings. These are the first 16 interviews, in-depth interviews. We're actually now at about 25, and these themes are holding as we've increased the numbers. So first of all, in the ones that we selected for the criteria we used, 7 of these 16 sites are only using the transitional care model, but 9 of 16 are using multiple models. And what does that mean? I was talking to Claire this morning. Here you could have in a hospital system, for example, the cardiac division that has selected to use Project Boost. And these are different models for those of you that are not in the world of transitional care. Project Boost and the Hospitalist Society has really been a major leader of that, or Project Red, Brian Jack, re-engineering discharge planning. So these are different models that have evolved and been tested to have positive impact. So in that same hospital, the pulmonary division might have selected to use Project Red. So you have cardiac Project Boost and pulmonary Project Red. But many people, patients, have cardiopulmonary disease. So they're interacting. I mean, that's part of what you're learning in this process, that these multiple coexisting models they exist, but not necessarily is that known to the clinicians who are involved in the care of patients. And that, I think, is important as we go forward. We learned that RNs alone or in combination with other clinicians, what were some of the reasons that was happening? And here is where we were also seeing other kinds of adaptations creeping in, where people are using RNs because they're much more emphasizing the care coordination role, the case management role, as we traditionally know it. How it is to make sure that Mr. Smith has a primary care appointment set up before he leaves the hospital. Those kinds of things. Focus more on educating patients in terms of their work. In APNs, when they were used because people and systems were placing much more of attention on the care delivery end, where really exquisite clinical skills and assessment in managing complex patient symptoms are really required, not just in the hospital, but in the home, in order to be able to achieve the goals. The other area, this is a common adaptation, as I mentioned to you, post-discharge care without home visits or with telephone. And this, again, gets back to why did these systems, what were they hoping to achieve? And the systems that chose to either use telephone follow-up or not to have as much attention to home visits were really, again, focused on this notion that we can improve care coordination and education without that kind of continuity. So some of the barriers, as we just describe them, the services, again, are provided by more than one organization. So here in the same community, you have, for example, in the Affordable Care Act, $500 million been allocated to community-based organizations to improve care transitions. They might have started, the community-based organization, thinking, well, we'll start with the Coleman approach. But they're working with hospitals that are using the Naylor approach. I mean, so you can see the challenges when you're going across sites, and this is what this service line is all about. It's all about connection of multiple clinicians across multiple sites. But we also learned that it didn't really matter. There were still gaps within sites. So for example, there are many sites where clinicians have access to information in the electronic health record, but are not able to record or document in those records. 7 out of 16 of these sites said, you know, we have these transitional care nurses or social workers delivering these services, and they can't document in our records. So how do we promote continuity with that? So these are some of the barriers across sites. A common one was that community-based physicians are not returning calls to clinicians delivering these services. So this was also very important to us because we wanted to really understand what were clinicians thinking they were achieving through this service. This is really important that you have a sense of what outcomes they thought they were getting to. And the majority, 16 of these in-depth interviews said, we know what we're about. We are here to help reduce rehospitalizations, improve activation, engagement, improve the experience for care. But 7 out of the 16, and again, this is holding as our interviews are growing, said, we don't really know what this is about. We know it's a service, but we don't know. They could not articulate what they perceived the value of the service is, and that was important. And many then talked about their plans for the future, needing new tools, thinking that we're going to have to add new team members. Now that we've been into this, we now see that we have a very large population of people with behavioral health issues. We need more strength in our team to manage and help manage that care. Many are anticipating the kind of movement toward risk and thinking that we have to not just be focused on transitional care, but long-term follow-up of a population at risk in order to be able to achieve good outcomes. And many talked about the critical need to add capacity, which is more training. You know, we again have a workforce for which who do not, I should say, have the competencies in behavioral health, in patient engagement, in palliative care, in performance measurement, in all of these dimensions that we're now asking them to take on as they take on these new roles. So what we also decided to do, and this was not part of the grant, but we thought really important, was to augment some of these interviews, which are an hour or an hour and a half, with actual on-site interview days that we spent. And these, so far we've conducted 3-day-long visits. What we've been astounded by is the level of support from the health systems whom we're reaching out to. Now we've been working with these health systems, our teams. So they're really anxious to tell us what they're learning. And in these day-long visits, we're talking to board members, leaders of the organization, patients, family caregivers, and the clinicians and partners in between. And so we're integrating findings from these with those from the interviews to understand, help amplify our understanding about TCM adaptations. I wanted to tell you a little bit about Trinitas. Trinitas is a facility in northern New Jersey. We began working with them about 4 years ago to implement the transitional care model. And they had funding from lots of sources at that time. But here's what I want to tell you about their adaptations, the deliberate adaptations. They actually had a Wharton grad on their board who knew about our work and who funded the advanced practice nurses for the implementation of that. So it always helps to know all these things. But anyway, Trinitas is in an impoverished neighborhood. I mean, the people many are homeless, but almost all those served by this system, which is the result of consolidation of 3 smaller hospitals, are really what you would describe as the most vulnerable, even if they do have housing. Within about 6 months of implementation of the transitional care model, what happens is your eyes become open to the challenges people confront once they leave the walls of your hospital. And they immediately knew that people were going home without food. So they established, and this could be called an adaptation, but a partnership with the food bank. The lead in the food bank, chef, came in and worked with the clinicians to develop a meal plan so that everyone who was leaving there would leave with meals for at least the first week to 2 weeks that they could freeze that were tasteful, but also appropriately the right stuff for people with heart failure or diabetes and so on. So they immediately see that. They also figure out that many of these people have service needs that are not being addressed by social services that exist within the community because they haven't been connected with them. So they build a relationship with aging. They build a relationship with community pharmacists who are continuing the work of helping people who are living with complex conditions, often with multiple medications, figuring out how to help them to make sure that the education and work that started in the hospital. So you can see what happens. They have now built a set of adaptations that are the result of deliberate understanding of what's happening to the people in their population and their efforts to respond to it. We think this is a great example of how adaptation adds value. Because it's deliberately focused on the needs of the population in the community. So here are some things that we don't know and would love to go back to many funders to find out. But you know, we are asking about perceived outcomes. You know, the clinicians to tell us, what do you think is happening here? And what are the goals that you should be working toward? But we don't actually know what are the outcomes in these organizations for which there have been adaptations. And I think that that's exceedingly important. We also are beginning to understand the complexity of studying adaptation and how do you account for multiple models both within organizations and across organizations. How do you really rigorously understand the implications of adaptations when it is that complex? And that's what our health system has increasingly done in response to decreasing fragmentation. Does the nature of adaptations change based on the lead organization? So if a major grant was given by CMMI to community-based organizations to improve relationships with physicians, with their hospital systems, does that influence the adaptations that are selected, et cetera? So we don't know whether or not it does. But we also want to know, how does it affect your partners? So if a lead selects an approach, et cetera, how have you really galvanized your partners to be able and position them to be able to adapt that? And then, you know, beyond clinicians, what we love about these site visits is we're sitting in meetings with the chief financial officers and all of these other people whose perspectives on this are exceedingly important. The leadership team's perspectives on adaptation and what's going on in their systems, I think, are exceedingly important. So that's my walk through what we've been doing in the last couple of months, trying to figure out, if we're really going to move evidence into systems, how can we do it very deliberately and learn from it? But how can we really acknowledge that great systems are not and shouldn't adapt in whole everything that an evidence-based approach set out to do? Because this notion of fidelity is important. It's exceedingly important, but fidelity has to be aligned to what we know about core components of a model. And where is it that the tweaking can get us to someplace better? The tweaking that occurs because it's my organization, these are the populations I'm serving, this is the cultural, these are the strengths we're already bringing to this. And we want to make it, these things will work to the extent that they are owned by the system, by the community. And they will not work, as we have learned, if people think you're coming in and imposing something without really knowing who they are. So we spend a lot of our time trying to get to know health systems, communities, values, in order to think, before we ever think about how it is that we can help them accelerate system redesign to accommodate and accomplish what they want to achieve. So that's part of what we're learning. And I welcome your questions or comments.
It's an amazing body of work. Thank you so much for the walkthrough. I wondered if you could say a little bit more about how you worked with Aetna to get systems to adopt the program.
Right.
Was there a financial incentive involved?
So the first effort to see whether or not we could actually replicate findings from the NIH was supported by multiple foundations, which in and of itself was a story. To get 5 foundations thinking about how they could collaborate in partnering this. And it was guided by a national advisory committee that included major payers. We included people, when we think about advisory committees, we think about who are the stakeholders we're trying to convince with this work. So we included other payers, the National Quality Forum, thinking about what measures are important to really promote, to endorse such an approach to care. So patients, family caregivers, clinical leaders. From that point on, the story unfolds, and I'm going to take you down 2 paths. One was we were able, in our health system, finally, and I think this was, a real, here's what I did. I come back from all of my national meetings and I said, every time a hand will shoot up and say, well, is Penn using this? So, I sit in the School of Nursing and all our colleagues, we're outside of the health system, but they want to know, is our health system implementing this as a service model? That ultimately led our health system leaders to give us $1 million to map this out within our own health system, build a service line, figure out how we were going to recruit the positions, how we were going to make it happen within our health system, which has 3 major hospitals and lots of primary care practices and multiple affiliations with post-acute skilled nursing facilities and hospice organizations. And so we did that. And then we had pretty, the combination of the data from our initial work with Aetna and our own health system enabled us to go to payers. Aetna was already on board, but then to add IBC. And what's happening now, at least in our health system as an example, is that the payers are paying a case rate for the delivery of this service line. So this is Medicare managed care payers for this service line for their members who meet high-risk criteria and so on. And then they're judging us based on performance, on an agreed-upon set of metrics, domains which I listed: quality of care, symptom status, experience with care, and rehospitalizations, emergency room visits, total cost. And they are then determining, so the system gets a case rate per member for the service, But then reconciliation is occurring to see how well we did on these, to see whether or not the service line will continue, will grow, which it is growing, based on the performance that we're showing. Or ultimately someday where this prophet will lose her head, which is, we fail because it's a risk-bearing contract. And if they don't meet their mark in terms of, being able to demonstrate improved performance, especially in the cost factor, then the system is taking on risk. So that's how. I would say, though, that other systems, for example, we're working with accountable care organizations who are vitally interested. They've already taken on, most of them, one-sided risk, but many are preparing themselves for full shared risk, are taking this on. But managed care, I would say, has the greatest interest in this right now. Let me tell you also about a project that we're involved in that I think is going to be very important in terms of moving this. And what I'm talking about, though, it's slow. This process of moving evidence into local health systems and communities is slow, and it's sporadic. So we have stuff going on, and we feel really proud of having 350 organizations that we know of the 580 using, about 60% using evidence from our work, but that's absolutely too slow. So we've begun work, our team with a partnership with Stevens Institute of Technology to develop a simulation so that we can take data from our work and present it to decision makers in their health systems and communities to show if they were to use this, how it would impact the people that they're serving. Stevens has this unbelievable simulation model that now is literally using our data. We've brought onto the advisory committee for this Jonathan Blum, former CMS, Lou Sandy from United Healthcare, health system leaders from large systems, and they're helping us design the simulation with the perspective that if you want to come to purchasers, Pacific Group on Health, so if you want to come to us and make the case to us, this is what we will want you to tell us. And I think that this is all a part, we think this is a part of an effort to accelerate use, implementation. We cannot be relying on tools where our team goes to Idaho and then to, we can't do it one little system at a time, as much as that's been extraordinarily satisfying to me. I feel like this is all about impact. And so that's been really amazing, but we've got to change faster. And so that's another tool that we're using.
Hi, Mary. Thanks a lot. This is great information and will certainly help inform a couple of the things we're working on. A couple of quick questions. How do you define high risk, and is that something that's across the board, or is that something that each system adapts? And then the second one is about the staffing. We're looking at staffing in care coordination, and how much of a factor is the cost of the staff and the availability of the staff in these adaptations? We're seeing community health workers, medical assistants, some RNs having these titles that have something to do with care coordination and doing some of these pieces of work, usually supervised by an RN or someone. But how much of looking at the cost picture is part of that staffing arrangement?
So let me start with the staffing, and then I'll go back to the risk. We've always been challenged because we've used master's prepared nurses in this work. And part in the early stages, that was essential. It was central because we were not just using what we believed at the time were very sophisticated clinicians who are grounded in home and community largely. That's our history as nurses. But we were building knowledge, and so we needed to make sure that we had the clinical experts who could not only help us to understand what are the challenges and issues confronting people as they're making this journey, but also how to collaborate effectively with all of the team members. So it remains an empirical question And I think it should be asked, now that we've built evidence-based protocols and have these decision support tools and so on, whether or not we need to rely on advanced practice nurses. I would say this, that our own experience, and we have meetings weekly, case study presentations, use root cause analysis, is that the high risk, and the reason that's why I started with staffing, the vulnerabilities, the challenges that people are confronting that are related to their progression of health problems, related to the family issues that they're confronting, the housing issues that they're, so you know all this, the behavioral health issues. The level of challenges is absolutely still creating unbelievable angst for these nurses because they are absolutely committed to doing it. I should highlight, though, that they are supported by a team of, they can call on, we have experts that they can call on in geropsych and so on to be able to implement this work. In terms, we are often called a costly model. The challenge is cost to whom? So we've used a modified societal perspective to think about cost. So if you're talking about cost to a hospital for advanced practice nurse is much more than a registered nurse, and certainly more than a community health worker. But if you're talking about a hospital that's now entering into risk-bearing contract for a population, what you really want to think about is the return on investment that's long-term. And the vulnerable populations that we're working with require unbelievable upfront investment to get things positioned to be able to assure longer-term positive impact. The way that the model has evolved, is that we rely on the advanced practice nurse for that intensive phase. Now, I describe it as maybe if we pick people up in the hospital or we pick them up in the community, it usually takes a couple months to get people positioned or aligned with the services and make sure that they're well enough supported by their family caregivers in whom we've made no investment. So now we have family caregivers needing to learn how to deliver services. It usually takes a couple months. And then a decision is made about what is the next level of care that could be provided and what level of risk are people. So we've, and this is an acknowledged simplification, have 3 risk categories at that point. So the advanced practice nurse could hand off to primary care. Knowing that they've built a relationship with primary care, still on top of the population for the long haul, but these are people that are relatively stable now and really only need the good support, great support of primary care. There's a second group of people that are somewhat unstable who need more than that, and we will rely on either community health workers or registered nurses depending on the level of instability and the challenges, et cetera. Again, all reporting to the advanced practice nurse responsible for that. And the third level are those who are near at end of life. And there, the advanced practice nurse continues in the delivery of services for this population. And one of the real issues for us has been to build the palliative care competencies of these advanced practice nurses. So these are great, many of these were clinicians from the ICU who absolutely can, when they enter a relationship or they go with the patient to the first visit to their community-based provider, which is a core element here, building connections and relationship, can convince that clinician, look, you call me 10 days from now, I call you to say Mr. Smith's in having trouble, that they'll trust enough that that clinician knows what to do and collaborate and work it out so the knee-jerk isn't to send Mr. Smith to the emergency room. So I mean, to your point, I think the population health model that has evolved has a transitional care component with a longer-term follow-up based on risk, but with a need for somebody to be out there monitoring the whole population, because humans being what they are, they don't stay the same. And people who are low risk today can be jumping to high risk tomorrow, and somebody has to be nimble enough to adapt to that.
So I was really sort of inspired by your story of the implementation process, and noticed you mentioned a couple of different factors and wondered if you could reflect on the ones that were really crucial to the order, and the ones that I sort of noted here were sort of you need tailored tools, relationships and champions, evidence of effectiveness, cost savings, and then you mentioned this very interesting issue about sort of the protecting of the intellectual property and the name, and how that played out. And I'm wondering if you have any thoughts on which of those things were sort of crucial for implementation. We're thinking about sort of implementing a new process of care around surgery for older adults, and I think we've really struggled with which of these things should we be doing first, because clearly we need to do all of them,
Yeah.
and you can't do them all at once.
I think that they're all important, but I do want to get to the naming last. But I would put champions, relationships at the top of the list. So and I'm going to tell you a story. We implement this project with Aetna, and we had, this is like it's co-creation. This is designing this thing together, which, by the way, I think is also exceedingly important, having patients and family caregivers and the payers, really seeing that they're part of the design, that they're part of it, et cetera. But so we implement this, and we had, Randy Krakauer is on board, all the clinical managers and the systems on board. We had the health systems we were implementing this in, and so on. But here's what we thought right from the beginning. We cannot build this implementation as an add-on. I think that's a big mistake in implementation, saying we're going to take your existing system and now we're going to add this on. Because the first thing that can happen when there's a budget adjustment is that they'll pull the add-on out and you're lost. So we wanted to integrate it intimately into their existing system. So they have Aetna has a high-risk telephonic case management system. And what the way that they implement that is case managers, Aetna employees, are doing the screening of who's high risk. And we had worked out, all right, you're high risk for telephonic case management, but here are and we mutually agreed upon these, criteria that would make you high risk for now transitional care, which is expanding the walls of, in this case, I guess the phones, to include in-person visits and so on and so forth. We also establish it as a collaborative process with the case managers. So fast forward. We are into the project. We've got 5 foundations asking us, how you doing? And we realize we have very few people enrolled. And here's what happened. The case managers, we did not fully engage those case managers. The people on the ground that were responsible for helping, that actually were responsible for identifying the high-risk people. Make sure that you're working with all layers of the system. So we had the leaders, we had the middle managers, but we really did not do a good job with the case managers. To the point of evidence, I say, is important. Evidence gets you into the door, but absent relationships, you don't get a chance to get people to think about that. So we've learned this in our conversations with the leaders about who makes decisions. And the reason I was able to get them all on the advisory committee is I have relationships with all those people. So they are bombarded, and this is one of the things they're telling us, bombarded every day with someone with a new idea, a new technology, evidence-based. Everybody uses that word. And so sifting through this has now become, it's like a breakfast feast out there. I get calls every day with someone who has a new technology that will add value to the kind of work we do. So relationships get evidence to be able to move not just through the door, but into at least a reasonable look. It doesn't mean you're going to always win, but I think. So I would put that as number one. On the issue of naming models, I think this is really important. And I would say you could get all of us who have named models in a room. And ours, by the way, is not the Naylor model. I love it when you go to places and they say, we're using Naylor Light. It's like we're a beer now. Serious. We're using this part of it and this part. But the models, I think the evolution of science is such that, the models often are first generational. They're the ways in which we begin to know challenges and so on and learn about different approaches. But I think the real leaders in the field will have to come to grips with, where's the common ground in all of this? Where is it that we can integrate knowledge from all of this to get to a real population approach? Where is it that you might be able to take a population and say, well, look at it, if you're at this level of risk, then this approach matches. But if you're at a much lower level, then this matches. So I am concerned, about holding on to names. And I say that who has, we have a model, transitional care model. But really what's most important is how does knowledge gleaned from this and this work and the other stuff that we're doing really advance the field? And I think I look forward to the day when we don't have models, but we have evidence integrated from multiple approaches that add value. So that's my view.
The Northern New Jersey program you mentioned, the low-income community.
Trinitas, yes.
Right. Could you elaborate on the success factors? For example, were you able to integrate managed care Medicare and Medicaid? Was there philanthropy,
Gosh, okay, yeah.
aging funding?
So this is, and actually I have a brief 1 or 2 pages, so Joanne, if somebody wants to, but this is a big deal. I mean, and thank you for raising this. The initial funding for the integration of the transitional care model into Trinitas, which at that point was in the merger phase, consolidation phase of 3 Elizabeth Hospital and small hospitals, as I mentioned, came from multiple sources. This enlightened Wharton grad on the board, funding from the Grotto Fund, and I had gone to the Grotto Fund they defined an interest in transitional care in New Jersey, and I had gone and suggested some approaches. It was then what happens is they also received funding from CMMI. So it was sort of like the funding's building to be able to expand their work beyond the small startup. The challenge for them is that they have, so you say you, but this was the health system. The challenge for them is their path forward. At this point, they do not have Medicare managed care supporting the continued program. So they're relying largely on a philanthropic implementation. They've gotten tremendous attention, and they have recently brought payers to the table to think about their path forward for the duals from the state and so on. But they do not have secured, at least as of a couple months ago, it's been a couple months since I was there, secured a sustainable path forward. So I think that's going to be, and of course, and unfortunately, they have many of their population who are dual eligibles, and not necessarily the ones that you immediately think of being embraced by the emerging delivery models because of their complexity. So I think it's a huge challenge. Yesterday, Jeff Brenner announced that the Camden Coalition, which targets a very similar population, has started a national center, Atlantic Philanthropies, RWJ, and so on, and they are really tackling this issue of the economic sustainability of well-developed, well-integrated care delivery models for whom there's not a clear path forward in terms of payment. So I think, all of that's designed to be helpful, but to your point, I think, and yet in other communities, they've gotten the payers on board. It seems on the one hand, this is an absolute alignment if you think about the population long-term impact for Medicare managed care, and that's where we went first. But it also seems, because of the approaches, it's like one community or health system at a time trying to navigate that, and it's really tough. I don't think that we really can count on that as being our path forward. So I sit on MedPAC and believe very strongly that we've got to create the payment systems that enable this and many other kinds of care delivery to get to high value care for a growing Medicare population on the backs of many fewer employed people supporting it. So.
Well, thank you very much. Our time is up.
It was, thank you, really. Thank you for this opportunity.